This is going to be slightly different format from many of the other sessions you might have been at, except I hear the intimacy one that was here just immediately before had a loose format too. What we want to do with this is we're not going to be giving you lectures. It's going to be, it's kind of like I'm the Scottish New Zealand version of Oprah. And so there are 5 of us who are going to take part. We have Karen, who has a bleeding disorder. We have Paula James, who's a hematologist. We have Joanna, who has a bleeding disorder. And we have Richa, who is a psychologist from India. So I don't know if you want to come and sit a little bit further up to the front. Don't feel pressurized, but we're not going to do any hand-holding or anything like that, but you might feel a bit more involved.
But we could.
We could if you want, yeah. We could sit and squat. But what we thought we would just do, for us, we wanted to hear the voices of some women, 2 women who've got bleeding disorders. We want to hear from Richa about what the issues are related to psychological issues, but we also want to hear from people, you in the audience. So you want to hear your stories and your questions. So after we've had the initial opportunity to ask Karen and Joanna questions and heard from Richa, we will open it to the floor, and we want you to feel confident to come up and step forward. Sound good? All right, so we've got an hour and a half. If you get really bored, if you all start leaving, we'll know that you've had a long day and you want to go home. So we won't mind. We can finish early, and as Karen said, that way you all get a little bit more time. And we won't take offence if after an hour you're tired. Okay? So Paula's going to start the questioning off. So Paula James can introduce herself, and I'm going to sit down here at the front. Okay.
Thanks, Claire. So can people hear me okay at the back? Yeah, okay, great. If it becomes a problem, you guys just give us a wave, and we'll optimize, because we have heard that maybe the acoustics at the back of this room are a bit challenging. So I'm Paula James. I'm an adult hematologist from Kingston, Ontario, which is kind of halfway between Toronto and Montreal. And I run a Women and Bleeding Disorders clinic there, where we care for women with a variety of bleeding disorders, myself, Dr. Mariana Silva, who's my pediatric colleague, and Dr. Marianne Jameson, who's an obstetrician gynecologist that I work with. So I'm pleased to be here today, because I think as healthcare professionals, one of the most important things we can do is listen to our patients and try to understand their stories better and what the impact of these diseases are on their lives. So we're going to start with my fellow Canadian. And just keep this fairly loose. But to start with, why don't you tell us about yourself and your bleeding disorder and what age you became aware of the problem, and just tell us your story.
So we have 5 hours? Okay. No, I'm kidding. So my name is Karen Fahey. I'm 52 years young. I'm a mother of 2 daughters, 2 dogs, and a recent betta fish. I've been married, it'll be 26 years tomorrow, so my husband's coming to meet me tomorrow to celebrate. In my professional life, I'm a strategic distribution manager with 3M Canada, with the Industrial and Occupational Health and Safety Division. And I am a factor 7, I have a factor 7 deficiency. As far as a formal diagnosis, I really didn't get that. I'm going to say formally, where I have a documented in a letter and a paper that says, you, Karen Fahey, have this. That only came forward in March of 2017. So my journey started as a child, where my dad, we had suspicions of a bleeding disorder. He went through many, many, many years of testing, with myself, starting at the age of 8. Throughout life, basically we were focused on my dad and my brother. So my dad and my brother basically showed a lot of bleeding symptoms, bleeding noses, bruising, bleeding extensively through cuts and whatnot. My issues really began when I became a young woman, when I began to menstruate. I began to experience a lot of challenges, a lot of difficulties just with learning to become a woman and dealing with that in itself. not having a lot of access to information. My parents at that point were not fully informed on the different types of bleeding disorders that were available or what they would be able to bring forward as information and whatnot. And it was kind of felt at the time that Karen just struggled taking care of herself because Karen was having little incidents and accidents on school buses, in school. So it brought a lot of pressures and strains just trying to, get into adulthood. What that did throughout the years, we just kind of mucked along. And it was really in my 40s that it was very apparent that this bleeding issue had to be dealt with. It had gotten to a point where it was so excessive I could barely function at work. I was anemic all of the time, couldn't focus. Extreme fatigue held me back from even social activities. And then as we moved forward, I continued to try to adjust with life. And as we moved forward, we started kind of making pressures to make sure that we got tested and got diagnosed. So my dad, my brother were involved heavily in that. And I started pushing for attention around myself. I said there must be something going on with me. My daughter was going to get surgery. My oldest daughter, who was also diagnosed with factor VII deficiency at the same time as I was. But at that point, she was going to get her adenoids removed. And we took some necessary precautions at that point when we raised the flag of our concern. We put quite a lot of pressure on the physicians to do something, even though we didn't have a formal diagnosis, but they did do some testing and saw some red flags. Really what happened, I kind of thank Alana, my daughter, that in a way, in a sad little way, she had complications. And they dealt with it and she was fine, but those complications led to further investigation. So at the age of 40 is really when they began to dive in. And I started to take a medication called Depo-Provera, taking shots I think it was every 3 months at the time. And I took that for 5 years. And what happened is one of the side effects to that medication was false sense of hunger. So, and I love food already to begin with, so the combination caused excessive weight. So when you talk about how I was feeling about myself and depression and all these things, this just kind of impacted everything. We had to stop those injections. It came to a point that it was highly recommended that that needed to stop. And we decided at that point that another option would be the IUD that I could use to control my bleeding that had the Depo-Provera in it. And a small incident happened is in the insertion of the IUD, my uterus was pierced. So unfortunately, and the IUD, the whole point of it was to avoid a hysterectomy because that would have been problematic. So I got sold on that. So really, 2 weeks after having this put in, I was informed that I was going to have to go down the road that I did not want to go down, which was having surgery. So although all the work was put together to ensure that we had a strong protocol to keep me safe in that surgery, keep in mind, I still had not had a formal diagnosis, so there were still a lot of questions and unknowns. So even to prepare for the surgery, that presented some complexities. The long and short of it is that kind of backfired. So that surgery led to having a hemorrhage that brought me back in the hospital. I had a second surgery to kind of correct the situation. Was a recipient transfusions, received hepatitis B, contracted hepatitis B as a result. Post-traumatic stress had to be dealt with after that. It took me 2 years to get back on my feet, get back to work, get the family back in order. And basically, I could say that after those 2 years is when my life really started, because although we had everything fixed after that point, the day-to-day effects of my bleeding disorder had gone. All I had to deal with now were kind of the silent effects. So that's in case I'm in a car accident or I need surgery. So kind of like it took away the day-to-day strain. Now I can focus and worry on other things. But I was also now able to focus on my family, create a new energy in my household, take my career to another level, which I wasn't able to do before. And I worked hard on building my confidence and my self-esteem, which is why I'm here in front of me, because I wouldn't have been able to do this prior to all that. So in short, that's kind of, it's kind of 52 years of a story.
So that's remarkable. And so was the surgery and the complications of the surgery 2 years ago, or how long ago was that?
So that would have been 12 years.
Okay.
2007 is when I had the surgery.
Okay. So you are the picture of resiliency, because actually looking at you today, I would have never known all of those challenges that you went through. And you've touched on a lot of the things actually that we wanted to hear about today, how it affected your day-to-day life. But I wonder if you want to delve into just a little bit more how this affected your personal relationships and your family.
Well, there's two ways to look at it. So there would have been my professional kind of world, so relationships at work. So I'll go there first, and then I'll go to the family relationships. But at work, what you do is you're hiding a lot of it, and you're going to work and you're feeling drained and tired and you can't focus. So you have to deal with your performance. So you end up having performance concerns, which puts stress on you, and you almost go into panic mode. So a lot of the times I found myself in a panic mode, so I wasn't at my best in my job. So now you end your day and you take that home. So you're coming home, you're not feeling good about yourself, you're still tired, your kids have needs, the cat has needs, the betta fish has needs, the husband has needs, the house has needs, and a lot of it would be overwhelming. So I wasn't my best self, I'll be honest with you. I would isolate. There were times I would say, okay, I'm going to my room. And then everybody knew, she just needs to be left alone. My daughter, later in life, told me that was the thing that hurt her the most. She said that she felt rejected. So I was going in my room to kind of make myself a better me when I came out of the room. But when you understand a 5-year-old wants to tell you about something that happened at school, and I've isolated in the room, that wasn't good. So that's kind of how I was coping. For me, it was coping. It wasn't really trying to be a bad me, but it was just trying to find coping mechanisms to be a better me under the circumstances.
Well, I want to keep hearing that story, but actually what I would like to now do is just ask Joanna Baquero, who is our next patient, the same questions. So, Joanna, you tell us about yourself, about your bleeding disorder, about your life with your bleeding disorder.
Okay.
Thanks.
Sure. Okay, so hello everyone. My name is Joanna Vaquero. I am 40 years young, as you mentioned as well. Actually 41. I won't skip that year. So I have afibrinogenemia, which is factor 1 deficiency. And just to put it a bit into perspective for everyone that's in the room, hemophilia is 1 in 10,000. Afibrinogenemia is 1 in a million. So I'm truly unique in that way. And it is an inherited bleeding disorder. As you know, there's a lot of these rare bleeding disorders as they classify them, but I have actually been very pleasantly surprised to see in this conference that there's a lot of focus on rare bleeding disorders, which is great. I am a marketing director at Colgate-Palmolive in New York City, and I'm originally from Colombia. I moved to the US to get my MBA, and after that I stayed working in the US. When I was diagnosed, it was when I was born. So my umbilical cord did not heal, and that was the first signal of having afibrinogenemia. And as well, my brother, we are 3 siblings, my oldest brother also has afibrinogenemia. So they knew that I was also affected. In terms of how it has affected me, it kind of like got from less to worst, I would say, in the years as I was growing up. So growing up, of course, when you're playing as a kid, you are falling down, you're getting bruises, a lot of growing pains, as I call them, because my legs would hurt, and so I would have to get cryoprecipitate transfusions. With that came hepatitis B infection. And then I would have also, you know, the nosebleeds and things like that. When I got my period, that was very hard. I bled a lot in my first 2 or 3 periods, and because I bled so much, I got anemic to the point that it was beyond using pads, but basically just sitting at the toilet because I was bleeding so much. So at that point, my mother took me to the gynecologist, and I was put on birth control pills. And interestingly, I mean, to the talk that Dr. Claire this morning was talking about menstruation and periods, it was actually, not having my periods was actually something very isolating for me. Because while my friends were dealing with, you know, acne and cramps and all of these things that a young girl is going through, I didn't go through any of that. I just skipped it all. And I started having my period at age 38. So, so that's just a contrast to see that actually something good can actually not be that good. And then after that was when the real problem started to happen. At age 13, I had my first intracranial bleed. I have survived 7 intracranial bleeds. I've had subdural hematomas, and I wrote these down because I'm not a doctor. So I've had subdural hematomas, I've had bleeds in the cerebellum, bleeds in the occipital lobe, with shifting in the midline and risk of herniation. For the doctors in the room to know the cause of, like, the severity of the bleeds that I had. So after the bleeds, then I finally was put into prophylaxis. I had a port inserted, and that's how I do prophylaxis myself. After the port insertion, I had a pulmonary embolism and survived that. And to top it all off, as if it was not enough, I had breast cancer. So I got breast cancer at age 35, and only after having gone through chemo and all of that, I can say now that I am safe, and I am here.
I'll ask questions from here because that mic was clearly getting in someone's way. How then, Joanna, would you say that your bleeding disorders impacted your personal or family lives?
I see it as impacting it both positive and negative. On my personal side, I would say positive because it made my relationship with my family very tight. I mean, I have my parents today here with me, so that will say a lot on how close we are as a family.
Hola.
And like with my siblings as well. From the negative side, I will say my sister, my sister that's the one in the middle, she doesn't have any bleeding disorder. And I will say that I think it impacted her a lot because my parents were very much focused on me and then my brother and then her. So I think it did have an impact on her. On the friendship side, I think that positively, I mean, my friends are like my second family. They accept me for who I am, and they accept me with all the challenges that I have. So I think I cherish them a lot. I think on the negative side, though, you do become very isolated. You do not engage into a lot of other normal activities that other kids do. So I didn't have that much, like a lot of friends growing up. And even as an adult, I mean, I don't do a lot of other things, like things that normal people can do, like, going surfing or going to other types of activities. I don't do any of that. So I think that. And then in terms of the, more romantic relationships, if you call that, it's hard. It's hard to meet people and to tell them about the bleeding disorder, which I feel that it's actually, the previous talk was actually very relevant to me.
Mm. Thank you. Well, look, I might take this opportunity now to introduce Richa Mohan, who she can tell us about herself. And she deals with psychological issues. And just once she's introduced herself, she can maybe just tell us in her experience what psychological challenges and issues she commonly sees in women faced with bleeding disorders. Over to you.
So hello, I'm Richa Mohan and I'm from Delhi, India. I'm a psychologist and I work with, do a lot of women workshops in my country, as well as being a WFH volunteer. I have also done workshops for women in different countries. I am sitting as a chair of psychosocial committee, and we have also developed modules for women and girls on the psychosocial curriculum for that. The session title is Women Issues, Women Voices, and I'm very happy that the women voices are heard, and it is I'm seeing the session right from the morning that the women are there. So we are being heard. Coming to the issues or the psychosocial issues which came out in these women workshops in different countries, I will like to bring a lot cultural thing into it, because of course what these two have said is very common to other women as all over, but there is with our country and the countries like others, there exist the issues which are stigma, the guilt, lot of guilt, and the questioning, why me? It is the self-esteem issues which you have said, and so the women with a lot of self-esteem, they have less confidence in themselves, and that is how they are not able to recognize what is happening with them. Another is the support system of the family, of course, but when it comes to marriages, like for example, in our culture, marriages are generally arranged. So when it is marriage, it is very, very difficult to deal with for the parents as well as for the women itself. When it comes to dating and friendship, it is again very difficult, and then there the issue of disclosure comes in between. What to disclose, when to disclose, and how much to disclose. So those are the issues which are very, very important. Then even for the treatment, the accessibility, where to go, and whom to go and talk to. So those are the issues not only for the women, but also for the families which is existed. And these has all come from those workshops by the women themselves. Partly, they also, because we do it in a workshop more in the sense, because if it comes through them, they acknowledge the issues which is happening, and that is how they will help themselves. The unavailability of the information and education in different countries is again very low. So it is a lot of a struggle right from the birth till whatever age. It is a struggle for them to get the information, get the education, where to go. And I would also like to bring in not only the women with bleeding disorder, but women who are carriers. So with the carriers, the carrier testing is again an issue. When to test the daughter, the carrier daughter. So that is an issue. And with all these issues comes a range of emotions which is very, very difficult to deal with. But it can be dealt with. So like being totally shocked, being afraid of the impact of a relationship and her current and future children. With the birth of the baby with hemophilia, the mother has to face the possibility that her sisters are also carriers, and it can affect on the family. Having a sense of loss at feeling different from other women. Delayed diagnosis is again a very, very big issue for these women, and can lead to psychological manifestations such as anger, anxiety, fear, like all sorts of confusion as what is happening with me. And of course, as absenteeism because of the heavy menstrual periods for a longer period of time, absenteeism from the school, and dropout from the education, and then it affects the carriership when they grow older. So these are some of the issues with related emotions is what we have found in our study. Thank you.
So what I'm really interested in, before we ask the audience for any input, is, so Karen and Joanna, when you were growing up and, you know, all of these things were going on, did you feel that the healthcare providers who were looking after you had even the tools or the ability to help address some of the issues that you were faced with? Tell us about your experience with that.
I'm going to say that depending on the healthcare provider that I went to see, right, you have your general practitioner, your gynecologist, depending, I think in some cases they didn't have the necessary tools. And I think I didn't have the necessary tools either to articulate in a way to get attention to help each other out. I would say to you that that actually lasted for quite a bit for me until after my surgery, and I'll call out Dr. Rochelle Winnicott in this instance, who really, in my hospital room, said to me, we're going to take all this pent-up anger, we're going to take that energy, and we're going to do something with it, which is why I do what I do today. She was able to help me work on my attitude and do something about this, and felt that we could get some of the word out. So from that point on, with her coaching, it was clear to me that I had to become a partner with my caregivers. And by doing that, I committed myself to bringing information forward and bringing an understanding forward, educating myself on the tools that I needed to bring that forward. So depending on where I go, I still experience today that there are some folks that don't fully understand and may not even know how. Like, I get different reactions. I'll be honest, I get really, really different reactions. I get puzzlement, just like, or concern. The other thing is a high level of concern and almost fear, and this girl showed up, she's a ticking bomb, and she's in my office, and I have to take care of her. So it's basically been my experience to date.
Okay, so my experience has been somewhat similar. Just think about 1977, Colombia, South America. There was not much information about afibrinogenemia. Again, we're very rare. And sometimes going to hospitals, it would be like, oh, do you know afibrinogenemia? Not a clue. Okay, do you know hemophilia? Somehow. So that's how they would relate to a way of treating. Surprisingly enough, though, we moved in 1982 to Boston because of my dad's job, and we thought, wow, okay, we're coming to Boston. I'm going to be treated with very good care, and they didn't have a clue about afibrinogenemia either. So what I faced throughout my life has been a lot of lack of information, because afibrinogenemia in medical documents are a paragraph, and that's as much as the knowledge that doctors sometimes have. And even more so in ERs. When I would have to go to emergency rooms, they had no clue. I've been very fortunate, and I would say very blessed, that my sister became a doctor. And she is a gynecologist, and she knows more about my disorder than sometimes some hematologists that I've gone to. Because she grew up with me, she knew about my disorder growing up. She read a lot, and actually, I mean, a lot of the 7 times that I've survived intracranial bleeds was because she did a good call, and she told me go to the ER now, and I was in time to be helped. Other times when I needed, an MRI versus a CT scan and things like that, she would be my advocate. And so to that point, which is similar to what Karen is saying, I feel like for me, what has helped me now is having a team that I rely on, which is my doctor, my nurse, and even my social worker. They are the ones who help me out when I need something.
Can I just ask so I know there are a number of healthcare professionals in the room. What advice would the two of you give us to try to prevent some of the pain and suffering that you both went through?
Okay. Okay, so it's interesting that you mentioned that, because I actually brought my book. I wrote a book about my experience. It's called Driven by Hope, A True Story of Defying All Odds. You can find it on Amazon. And all the proceeds of the book are going towards research of rare bleeding disorders. Just a disclaimer there. Okay, so in my book, I talk about something very important, and is the way that doctors talk to us patients. A lot of the times when I've gone to the ER or I've gone to doctors to consult, they don't listen to me. And I get them to listen to me when my sister calls. And then it's a peer-to-peer conversation, and then they listen. A lot of times, especially for rare bleeding disorders, the patient knows more about it than you do. And I mean, I'm saying this in very humbly. I've had to live with this my whole life. And most likely, I know more about my body and about the things that work than the ones that don't. So it's been a struggle. I won't say that I've had, and I will also say that it's not always the case. I've had great doctors throughout my life. I've been very, very fortunate to have that. But I will say that the biggest advice and the biggest ask that I would have for doctors, new doctors especially, is the bedside manners. You know, listen to your patients, because they know a lot, and I know that you guys know a lot too, but it's a partnership and it's a team effort to get better and to be, you know, to be healthy again.
I think Joanne's captured it well. And when you say advice, again, there's different disciplines that we have to take into account, right? So some doctors and physicians are more sensitive and more aware of bleeding disorders. I think we have a responsibility when I'm in front of that audience to take a pulse of who I'm dealing with, what's my audience in general, because sometimes receptivity has to be there. So I might have to create the receptivity and get the attention. I'm also cognizant that physicians are very busy. Sometimes they're pulled out of a doctor's office to go tend to an emergency, and it's hard to get them focused in a clinic kind of environment. The main thing, if I were to generalize it, because I find it's hard to generalize, to give the feedback and say we would appreciate this kind of behavior, I think it starts with receptivity. You know, just taking the time to hear the story. You know, I gave you a short version of my story. It's complex. There really were a lot of things that happened in my life, and things that I can't necessarily back up with documents because I was undiagnosed until March of 2017. Now I can go to the pharmacy and I can give that letter, and I can take, you know, my care to a different level. So I think it starts with receptivity. But I also think it starts with myself advocating for my own care. It's got to be a partnership, and if it means having a crucial conversation with your doctor to get that conversation going, I think I'm responsible to start that. And if we don't have the receptivity, I think I need to consider another physician at that point. I own my business. So I have to take care of it. So I'm the manager of this, and I kind of see it that way. I think it goes both ways.
Well, thank you, both of you, for those pieces of advice. I guess one thing I would reflect on thinking about this is that my dealings with the healthcare system, personally and for my family, have been a few serious issues, minor issues. But one thing I remember, my father had a heart attack a few years ago, and I spent a lot of time with him in the hospital, and I'm actually speaking to the healthcare providers right now. One thing I remember was that people coming in the room sometimes wouldn't look us in the eye. And sometimes I think it was me, and they were intimidated or afraid of me, but it made an enormous difference for someone just to come in, and this sounds so silly, but to treat us like people who were going through a difficult situation, and to look us in the eye. That meant a huge amount, actually, for somebody to look right at us and to listen. So I think you've given good advice that all of us need to listen to. And for me as a physician, the busy comment is important, because we should never be too busy to look after somebody who needs to be looked after. Yeah.
So, I mean, there's bound to be some people in the audience who would like to say something, respond to what Karen or Joanna or Richa or Paula has said. Anyone game to come up? Anyone want to? Yes, come forward. There's a well, Actually, there's this microphone here at the front, or there's one over to the side as well. And while you're coming up, I think that thing, speaking as a doctor and a patient as well, the thing about doctors and people making out that you're too busy to deal with someone is in some sense, it's highly disrespectful. Yeah. It's that you don't care for them, and that's what we're there to do. So for me, and sometimes the days I am busy, I can see that I don't do that as well as other days, but it is really good to be reminded of that, so thank you. Please introduce yourself and tell us what you would like to say.
Yeah, I'm Sarla Rao. I have come from India, and I'm working with a group of girls and women in Bangalore. Excellent presentations by all of you. I just want to share a couple of observations. I personally feel that we don't have a right to decide regarding reproductive health. The girls cannot decide that whether she wants to have a child or whether she can adopt a child or whether she can go for IVF, unless we have these rights. Because the moment a girl gets married, within 6 months, if she doesn't become pregnant, then eyebrows are raised. So I feel that right to reproductive health, that's a very important thing which must happen. The second thing is the career testing. It is not easily available and it is somewhat costly. So even if we convince young girls who are from the hemophilic family, they don't have wherewithal from rural area to travel to city or state capital, stay there in a hotel for 24 hours and pay the expenses. It's very, very, very difficult. So these are the 2 points which I wanted to share with you. It was an excellent presentation. Thank you.
Thank you very much. You're coming. Come forward. Whoop, whoop. Don't be shy, everyone.
My name is Angela Lambing. I currently work for Bayer. I'm a nurse practitioner, but I ran a treatment center in Detroit for 15 years. So from the care provider side, I totally understand what you're going through. And a couple of suggestions. You mentioned the advocacy, having an advocate, how important that is. And I totally agree with that. I think another way that can be helpful, and I did it with all my patients, is give records, test results, office notes, everything that you can carry with you that will help picture your story to people who don't know. And one way that I found it was helpful in my own personal life was I have a daughter that was diagnosed with idiopathic anaphylaxis. And we actually had to go to the NIH to get treatment and so forth. And at one point, she had to change physicians. And I had all her records. And we would go into this physician, and she'd say, well, did you try that? Yeah, here's the result. Yeah. Well, what about this? Yeah, we did that. Here's the result. Do you think it? No, here's the result. What we're looking for is someone who's going to follow what NIH tells you to do. So I think the power of keeping records is extremely important. So that would be the only thing I would add. And go girls, you did a great job.
Thank you.
And it's a shame, because I've also taken care of dysfibrinogenemia, Detroit type, where there's only 23 in the country. And I had to be her advocate, you know, to make sure that she got the care that she needed.
So I'm glad you brought that up. You reminded me. So I would walk around with a purple file. I went so far as, no, it wasn't red. It was purple's my favorite color. It was a purple file, and I had gone so far as getting the details records, my grandmother's records, which were in microfiche. So I went that far back, and the file was about that thick. So in the early stages of being followed at the clinic, they would refer to me as the lady with the purple file is here. So I agree that having as much as that was really beneficial for me to kind of have that crucial conversation, was to be able to pull those records out quickly to help the process along. And we've taken it a step further, because after receiving the formal diagnoses, I'm kind of the advocate for my whole family, so my brother, my sister, and cousins and whatnot. So we're encouraging the whole family to create their own purple file so that they can articulate their version of the problem.
I was going to say, like, I mean, since we were kids, actually, my mom, she would keep a login of the times that I had infusions, how many doses, and what was the event. And so I had that ever since the first day I was, like, the first day I was born, until, like, even with my bleeds and everything was kept. So I carried also my file. But when you get to the ER, you're not an emergency for them. So that's when advocacy is very, very important, because nobody's going to go through your huge file to say that you're saying the truth, that you do have afibrinogenemia. But thank you, yes, I do follow that.
Can I just make a comment, Claire? So I think what we're hearing is that what people have found effective is to figure out a way of speaking our language.
Yes.
So your sister can call and speak to a physician peer-to-peer. You've got your records. That's how physicians communicate with each other. I think we need to work on learning how to speak your language.
Yeah.
So, I mean, I honestly don't think this is all on patients. We've got a role to play here, too.
Yes, that's fair.
Come forward, yeah.
I will try to translate my mom.
Okay.
Soy María Belén de Argentina.
I am María Belén from Argentina.
Y él es mi hijo.
And I am the son of María.
Qué guapo, ¿no?
Yes. Sí, sí, muy guapo. Mi papá tenía hemofilia.
My dad had hemophilia.
Y somos 4 hermanas mujeres,
And we are 4 sisters, women,
4 portadoras,
4 carrier of hemophilia.
Muchas experiencias variadas.
A lot of variety of experience.
Yo me casé, tuve a Pedro, que tiene hemofilia.
I married and I have me, Pedro, who have 20 years and hemophilia.
Después de 7 años llegó María Clara.
After 7 years, María Clara comes to the family.
Y nosotros queríamos saber si ella era portadora o no.
And we want to know if María Clara was a carrier or not.
Imposible.
Impossible.
Debíamos esperar que María Clara tuviera su primera regla para poder saber si era portadora o no.
We must to know if María Clara is carrier or not. We want to wait for the first menstruation.
Si total no importa, me decían los médicos.
The doctor says it doesn't matter.
Nosotros pensamos que si bien ella no tenía problemas,
We think that if Clara having problems,
además de que era nuestro derecho saber,
we think that it's our right to know if Clara is a carrier or not.
debíamos prestar atención a otros aspectos de la educación de Clara para que sea el diagnóstico que sea, ella lo pudiera afrontar.
We must to pay attention to some aspect for the education of María Clara if she was a carrier or not.
Decidimos hacerle la prueba, pero nosotros vivimos en el interior de Argentina, así que viajamos 700 kilómetros para ir a Buenos Aires.
We decided to travel 700 kilometers to do the exam for now.
Pero dijimos, bueno, el resultado tal vez es chica, tenía 6 años, aún no se lo vamos a decir.
Clara was 6 and we said that it's too child to know the result of the exam.
Viajamos, esperamos el resultado y cuando llegó el resultado era portadora y yo lloré más que con el diagnóstico de Pedro.
When the exam came to us, the exam confirmed that Clara was a carrier, and my mom said that she cried more than when she know my condition.
Sentía que esto no se iba a acabar nunca.
My mom feels that this, the hemophilia, never ends.
Al tiempo, Clara me pregunta, con 6 años, que qué había pasado con los estudios que le habían hecho.
With 6 years, Clara, a month later, asked my mom what happened with that exam.
Y en mi cabeza venía, le tenía que decir, no le tenía que decir, el médico me dijo que no, ¿qué le digo? ¿Cómo le explico?
And in my head, a lot of things, a lot of feels. I have to say I love to wait a time.
Y ella me miró y me dijo, mamá, entonces, ¿soy como vos?
My sister saw my mom and she asked her, Mom, I am like you?
Sí. Y me dijo, está todo ok. Qué suerte.
When I say, yes, Clara, you're a carrier like me, my sister say, okay, no problem. I'm happy to be like you.
Y empezamos a pensar que no estábamos haciendo tan mal las cosas.
And we start to think that the things, we do the things in the right way.
Y empezamos a ser felices todos los 4.
And all the family start to be more happy than after this.
Gracias.
Thank you.
Thank you very much.
Sweetest. That was just the sweetest. Thank you so much.
That was adorable. I agree. Katie Hines, I'm from Nova Scotia, Canada. Paula, we've met before, and how you had just made a comment about how you need to start speaking our language. I couldn't agree more with that. Coming from somebody who's an older sister of somebody with severe hemophilia, I had terrible periods throughout my teenage years, and I used to cry and cry and cry. I bled so much and argued with my doctors for years that something was wrong with me. And you're just a carrier, you're just a carrier, you're just a carrier. This is something I've been told my whole life. And it was something that I could not get educated on or anything because I didn't have a bleeding disorder. I just had a gene that made it possible for me to have a child with a bleeding disorder. And it wasn't until after I had said child with severe hemophilia A and hemorrhaged that they're like, yeah, okay, let's do some blood work. For me, the changing point in my life was growing up, going to summer camp, and I hope that a lot of people in this room can share that. And I just wanted to say that even for mothers of daughters that might not even be diagnosed, and if your child is going to camp, or make sure your child is going to camp. Even if they're not diagnosed as a carrier, growing up, going to camp with my brother, knowing that I was a carrier and meeting other people that had those similar, they had von Willebrand's disease, but their periods were just like mine, right? So nights away at camp, talking to other girls about my problems was great, right? And I'm fortunate that I got to go to such a great camp and learn from all these other people. And that made me accept my carrier status and accept what was wrong with me, even without a diagnosis. Far, far before a diagnosis, I was okay with it. So I just wanted to say, if you have daughters in the room, send them to camp, okay? Send them to camp.
Thank you very much.
Hello, I'm Yannick from France, and I want to say to all of you, I can explain you an example. When I was a youngster, I had bleeding troubles. I have heavy periods, and I was running always to the toilets at the breaks at school. It was funny because it was my surname. I'm the queen of running to the toilets. And now in Vilnius, there was a EHC conference, and a young women member of our committee was speaking with a young man, and he said, I'm a carrier, and he asked her, and what about your periods? Things are changing, I think.
That's fantastic.
Thank you.
Hi there.
Hi, I'm Roz from the UK. I've got type 3 von Willebrand's. I just wanted to pick up on a couple of things that people have said. I was diagnosed very young, which was quite lucky, and it was because my GP actually knew about it and spotted it in me and referred me for testing, so I was about 6 months old. And my mum, from then on, kept a diary. So a bit like your mum, she sort of recorded everything that happened, every bleed, every trip to hospital, every injection. And from that, she actually, like yourself, wrote a book. And in the book, she talked about my diagnosis, my first appointment with the consultant haematologist. And as part of her sort of, when she first published the book, she sent the book to my doctor, who I'd actually known all my childhood. You know, he was like a second father because I grew up with him pretty much, as were the nurses at the hospital. They were, you know, pretty much family by that point. And in the book, she'd said the first appointment that we had with him, when he was basically telling her that her daughter had got this severe bleeding disorder, which when she adopted me was the one thing that she really didn't want to be dealing with, and she was just finding out that was actually what was happening, he didn't look at her. He looked anywhere but in her eyes. He was looking all over the place. Now, he said when he read the book, he didn't even realise he did that. He had no idea that he didn't look at people, and he was always like that. He just looked back. So, in actual fact, sometimes I think you need to almost spell things out that you think perhaps are obvious, just to get the point across. And the other thing I just wanted to talk about was, you know, I was lucky getting diagnosed early and getting the care that I needed to be able to pretty much live a reasonable life given the limitations. But what's still sort of frustrating is that I've met women here in, you know, today that are from first world countries who are presenting with bleeding problems to their physicians and aren't getting anywhere. And I've been back time and time again with the same problems and are still not getting anywhere. So I kind of want to do something about that, but I'm not quite sure where to start, because as a patient, I'm happy to advocate for others, but I almost feel like, obviously, the first port of call here is your GP. How do I get to GPs and kind of say to them, look, this is what you need to look out for? I know they've got a lot of other things to think about, but I'm wondering how we can do that.
Good question. Well, look,
I'll leave that with you.
It's interesting. As a doctor going through medical school, you know, the amount of teaching that we get in haematology, never mind bleeding disorders and thrombosis, is really, really small. And I got to be honest with you, I didn't fully understand the coagulation cascade until I was studying to be a haematologist. But I got through medical school, and you can, you know. So we need to do. You know, you'd like to think that in the age of Google and the internet, you know, there could be, you know, even something really simple, you know, like which bleeding symptoms should you be worried. You know, if your patient has these bleeding symptoms, you should worry about X, Y, and Z. Now, I know Paula's done some simple bleeding assessment tool things, but one of the problems that you're talking about is actually getting the doctors to read those in the first place. And within specialist hands, it works. But within a sort of more general population, it's actually, you know, there's so much information on Google that, in fact, it's too much information. Yes. Yeah. But I think that's a challenge that you've given us that I think I think that this group of women within the World Federation of Hemophilia should take on board, actually. Paula, do you want to make a comment?
Yeah, I think it's a hugely important question. And I don't pretend to have all of the answers. I'll tell you about two things we've done locally. One is the bleeding disorder lecture that I give, half the time I give to a patient. So I teach half of it. A couple of my students are here, they can vouch. And one of my patients talks about what it's like to have von Willebrand's disease for the other half. And so I don't know if there are opportunities like that for you to get involved with. But I think if we start at the level of medical school, then these trainees and physicians will grow up with a different understanding. You know, I think if they hear those voices early, they'll understand better what it means. So that's one thought. The other thing that we did in Kingston with a number of my team who are in the room is I started a website, because this really frustrates me, because what would happen is, you know, people eventually would get to me, sometimes probably not, and I don't even know about that. But, you know, they would tell the stories that you're all telling. It took 15 years. It took 30 years. I went to see my doctor 25 times about my periods, and I got told it was normal. And it makes me crazy. And so we started a website that you're welcome to have a look at called Let's Talk Period. And it's really all about trying to get information out there to people about what's normal, what's not normal. We have some plans to create part of it that would be tools for healthcare professionals. But the other thing that's on that site, Claire was alluding to, is a bleeding assessment tool. So it's like a quiz, like an app that's on the site that somebody can take, and you get a read on whether or not your bleeding symptoms are normal or abnormal. By answering a whole series of questions, you get a bleeding score, and we know normal individuals who don't have a bleeding disorder, this is the kind of score they get, and here's where it starts to become abnormal. And so if you've got if you know somebody who's struggling, you could perhaps direct them to the site, they could take this test, and then you can print it. So you could actually take it to your physician and say, listen, this person who cares a lot about bleeding disorders, you know, and who is a physician, developed this thing, and her tool is telling me that there's a problem. I don't know if that would help, but is maybe somewhere to start if you're hearing about people who are struggling.
I hadn't thought of that, and I have actually done that, and I came out as abnormal, weirdly.
Just come and support Ros with that. 12 years ago, we started all this as the Hemophilia Society in the UK. We had Dr. Kadir, Deborah Pollard, and it all started. We have booklets, and we've worked hard for 10 or 12 years. And I hope we can just carry on doing more. Okay, thank you.
Thank you very much.
I just wanted to say it's important to keep feeding the energy of those that want to get involved. So my involvement started just by a testimonial, and that evolved to me becoming a member of the Canadian Hemophilia Quebec chapter board. So I currently sit on the board as part of the board of executives as a secretary. And I also, and I'm seeing some folks I'm recognizing in the room, I'm also an ambassador for Code Rouge when women bleed too much. So I think any area that you choose to get involved will have a ripple effect. And over time, you know, you will kind of develop the area of interest where you'll be able to create the biggest influence, because what you want to do is be able to move that needle. And we need women like you all over the world. There's still a lot of work to do. I mean, we're just starting to get the awareness out there. So we shouldn't get overwhelmed with the task at hand, and I would suggest that you hook on to one little thing that resonates with you, that you feel you can make an immediate impact, and then that will lead to further impact. But if we look for something that's too big, we might discourage ourselves, and that's the problem with volunteering, like getting folks to be able to come forward to volunteer. I think sometimes the task may feel too heavy-weighted for them. But just encouraging someone, even I'm doing my work here right now, encouraging folks to engage is critical to help move the needle, because we're not going to boil the water and overnight.
I just got one quick...
Certainly, on you go.
I've done a couple of things over the years. I did a talk for the training school for gynecologists and obstetricians, But that was quite a long time ago now, so there's been plenty since then that I've missed. And also, I was asked by one of the pharmaceuticals to do a talk for their reps, and they really found it valuable because they hadn't actually spoken to an actual patient that used their actual product. So it was a matter of, this is what it's like living with this that we are helping to fix. So actually it was quite good for them as well. Something that's occurred to me this WorldFed is that one thing we've got in the UK is a really strong network of something called the Women's Institute, which is groups of women that get together and, you know, support one another and do activities and have people go and speak. Now, what I'm wondering is, shall I contact all the groups and say, I'm willing to come and give a talk about bleeding? Sounds like
the opportunity to do it now, there's a big move on women in leadership roles. A lot of corporates and organizations right now are putting emphasis on developing women in the business environment, but that also includes, you know, doing things and advocating for things like that. So you're actually cresting on an environment that would encourage those kinds of things. But every level of engagement counts. Even if people point at my bruises, I figure it's an opportunity to do my pitch. So you pointed my bruise out, well, you better take 10 minutes because you're going to hear the story.
I've done that. Thank you very much.
Thank you. So just
good luck.
Please come forward. Yeah.
Okay. Sorry. Initially, I came up here because I wanted to make a comment about education when she said, what can we do about physicians that don't listen? And the biggest thing is education. And sometimes we have to have their own colleagues bring them that education. Like if you have another medical professional that knows about hemophilia or about von Willebrand's or any other bleeding disorder, they can bring that information to that physician, even making a phone call or anything like that. One of the biggest things is I'm really proud at how far we've come with women and bleeding disorders. My mother-in-law has she's considered, or she was considered a hemophilia carrier, but then after time, every time they kept doing her levels of the factor levels, they figured that she was always between 12 and 20%. So she was finally diagnosed with hemophilia, mild hemophilia, but still hemophilia. And there's so many women out there that don't know their levels that could actually be mild hemophiliacs and not really know that and not be treated correctly because of that. But one of the biggest things is that the more we learn the information, the more we become educated about it, the more we know the proper diagnosis that people are going to have to have, and the better care that women are going to be having in the future. So I just wanted to share that with you. She did have a spontaneous alveolar bleed, and at that point they tried to just put her on stymate, and then they realized that they had to give her factor as well. So so that's just one of the things that we need to kind of be looking into the future too. More women that are considered carriers are going to be called mild hemophiliacs, or maybe moderate, depending on how high their levels are.
And I think that's a great change that the WorldFed has made. Yeah.
Absolutely.
Thank you so much.
Yes.
So I thought maybe we could have Richa make a comment, and this woman here, and then the man behind her. So Richa, do you want to make a comment?
Yeah, so just a comment to what she has said. So this meeting like this at the WFH also makes a lot of difference to the healthcare professionals who come here. For 4 years back, a doctor came from India. She was here, a young doctor who has just come out with a practice of 5 years or something. And she was here, she was meeting with, and there was different sessions on women where she was a part of. And then she got interested. She came back and then wrote a proposal, also contacted her colleagues, and then got educated herself. And she has started a program that in India. So these meetings, and when you showcase your work and your tools, and so these are the learning tools for them as well. Thank you.
Thank you.
So I'm from Michigan and Detroit, Mary Jane Frey. And just in comment to the lady before me, there's a doctor in Michigan, Dr. Roshni Kulkarni. Many people know her, but her term is hemophilia.
Yes.
So that's the term for the women that are now being diagnosed with mild hemophilia. But we were talking earlier about keeping track of things. And there are some apps now available the Sisterhood app, which the Hemophilia Federation has sponsored, and there's period tracker, because when the patients come in and they say, oh, I've got all this bleeding, but is it, I'm changing my pad 10 times a day. Well, are you changing it 10 because it's full, or is it because it's, hygiene reasons? And those are in the countries that can actually do that, and I'm fully aware of that kind of stuff. But so we've been trying to do that, or there's the PBAC scores or something, so that we at least get some quantification to say, oh yeah, this is menorrhagia, this is not normal. And because I'm a pediatric, so I see a lot of young girls. We have a girls' clinic and stuff, and they have these heavy periods, but they don't necessarily have a bleeding disorder. So we have that to work with too. But with your ladies too, I have a dysfibrogenemias, I have factor 13 patients, and I'm always having to educate, because people like, well, what's that? Factor 2 deficiency, what's that? So you really do have to go out, and having a girls' clinic or a place for a woman to go to that understands, that may have a GYN and a physician there that will, kind of say, well, I handle the bleeding, but I handle the menorrhagia. So you have that together too. So I think educating everybody, even in third world countries, that they need some extra help with that too.
Thank you. Please come forward.
You probably wonder why an old codger like me is coming up at a women's conference, but it's my daughter actually is aged 32 and has severe von Willebrand's. First of all, I'd just like to say it makes you feel humble when you hear some of the struggles that you've been through, and it really takes the breath away, and real evidence of bravery there, and ability to just get on with your life, which I think is really admirable. I was going to just reiterate probably one or two small items, and then just say something that might be controversial, but I just thought I'd try and set the world alight a bit. Firstly, I think over the years with doctors, I think in the recent past they've all been pretty good, but I think one of the biggest problems in the earlier days was always, and it may not be a doctor thing, it may be a human nature thing, is this ability. It's nice to have the ability to challenge a person without being regarded as public enemy number one, a patient that you've got to avoid. And that's the feeling that some doctors in the past have given, and I'm sure they do to this day, and it makes it very difficult for the patient. You're in a very vulnerable position, and you feel as though you can't really get stuck in and ask questions. Access to doctors as a second point, and then the last one is, and I think it's been mentioned before, is lack of knowledge of some of these bleeding disorders at GP and especially dental level. Even dentists that we've been referred to have been pretty clueless at times about bleeding disorders and what the implications are as far as dental treatment is concerned. Then lastly, I'd just like to say, I've heard about women want to be heard and all that, but my issue is that, and it's not a criticism of anyone, because I think everyone's so well-intentioned, these conferences and so forth, that they're brilliant. So it's not a deliberate design, but all I see coming along here is 95% of it's been about haemophilia. And by definition, therefore, everyone else feels a little bit on the outside. Von Willebrand's accounts is the biggest single bleeding disorder. I know quite a lot of it's mild, but a fair bit of it's not mild. And then we hear all these other disorders, that same sort of problem. And yet we come along, I think there was an apology at the meeting I've just been to, that the last 5 minutes was about treatment of von Willebrand's. And I think that to me is a big issue. It's not a lack of intention of people, but it's the net product. And that's something, it'd be nice if somehow other people could start looking at that. That's the only points I want to make.
I think that's a very valid point. Thank you for making it. Thank you.
I actually, to your comment, I really appreciate what you said. On because in many cases when I've been in hospitals, I've been referred to as like nurse's nightmare, because I challenge and I ask, and why this and why that, because it gets to the point where you actually have to, it's your own life, right? You're vouching for yourself. So I completely agree with what you said. Thank you.
Please come forward.
I'm from the Philippines. I come from a family of bleeders. So my dad's side has hemophilia, my mom's side has von Willebrand disease, but my mom died of bleeding during an operation. She was 51 and she was undiagnosed back then. I grew up with menorrhagia, but I never knew. I was never diagnosed with anything until I gave birth to my daughter. I had 3 preterm births. When my daughter was 3 weeks old, she had nosebleeds, so we rushed her to the hospital. And I told about our family history of hemophilia and my mom's undiagnosed bleeding problem. My mom, before her operation, she told the doctors that she was a bleeder, and the doctors told her that she could not be because she was a woman. And when she died on the operating table, so they just said, oh, she was right. But we could not do anything about it, right? So when my daughter had this bleeding episode, she kept on having nosebleeds almost every day, and we were referred to so many doctors, and no one would say that she had a bleeding disorder because she's a girl. So again, it was so frustrating. And when she was 7 years old, I decided to take her to Hong Kong because I could not believe that she does not have any problem. So when the results came, I was also tested because of my family history. And true enough, when the results came out, we were diagnosed with von Willebrand type 2M. So I went back to all the doctors who saw my daughter over the years, maybe 15 of them. I gave them a result of the test that was given to us. And I realized that, as a parent or as a person with a bleeding disorder, you really have to strongly advocate for yourself. I joined our hemophilia organization in the Philippines, and even then they thought that women, mothers, carriers could not be classified as having hemophilia, and they wrongly believe. Even the doctors, I was surprised. Even the doctors would say, "Oh, von Willebrand only happens to women," and we do have von Willebrand who are boys. So I said, there even within the hematology society, there's so much lack of knowledge, and so we started to work together with my hematologist and my daughter's hematologist, that we start going to medical schools and talk to medical students. Just talk about our experience, and then it started, the information. But even within the hemophilia community, there's still so much lack of knowledge. And we have this member who has 2 sons with severe hemophilia. She experienced menorrhagia, and to the point that her blood drops her blood got dropped, that she had to be transfused. And we were advising her, why don't you see a hematologist? You have 2 boys with severe hemophilia. You could be given factors, right? And even her, she did not realize that she needed factors because, I'm just a carrier. The doctor told me I'm just a carrier. So now in our hemophilia organization, we really make it a point to educate our members, the mothers, that you may not just be a carrier. You could have hemophilia, and you would probably need treatment at some point in time. So I guess that's my, what I want to share is really encourage everyone to strongly advocate for yourself. Advocacy is so important, not just within the community, but more so with the doctors.
Thank you very much. You can be second, and yeah.
Hi, my name is Christine Pinio, and I'm from the United States. I was born in Switzerland. Hemophilia was in my family, but nobody believed me when I was bleeding. I nearly lost my life twice. Once when I had my tonsils out and ended up in intensive care for 3 weeks. And then again later on. I was diagnosed at 35. And even then, I didn't get proper treatment until I had compartment syndrome, and I almost lost my arm. So I think it is not so much that we don't as much advocate. I think the doctors need to take some responsibility for communicating. For instance, if you tell your GP that you have problems with your period, it's up to them to help you when you don't. In this country, we probably have the opportunity, but in many countries, they don't. And so it's up to the GP to say, look, you might have a problem, let's do some testing. None of the doctors communicate with each other, which is totally surprising. I mean, I had testing done lately, and my general practitioner had no clue what the results were, even though I asked them to send a report to them. So I think it is something that ought to be taught in medical school on how to communicate better with each other, not just with the patients, because it's really important that the doctors also communicate with each other.
Thank you very much.
Yeah, I agree with you completely. One of the barriers for us, and I'm not excusing it at all, I agree with you completely. And one of my nurses is sitting behind you, and actually one of the most effective things that we can do to look after my patients is actually to have her phone people. And so I agree with you completely that we need to communicate better. Privacy laws are a barrier to taking care of patients properly. And the fact that we've got siloed medical records, your purple folder resonates that I can't access results from an institution where I'm not an attending physician. And so the amount then of work that has to go into getting those records so that I can review them, I think that at a very high level has to completely shift. Yeah. Because it makes it really hard for us to communicate with each other, because there are barriers to doing that are systemic.
Oh, I understand that, and I know privacy laws. I was working in an ER for 25 years.
We could talk better to each other as well, though. I'm not discounting your point at all.
Absolutely. But, then there needs to be, as you said, there needs to be something done, maybe internationally, that, you can somehow sign releases and, do that kind of thing so this can be transmitted better.
Yep.
Thanks.
So I think if you have one final comment, please come forward. And then I'd just like to ask, after your comment, the panel members just to make one final comment.
Sure.
Please.
So hi, everybody. I'm Lisa. I'm actually Dr. James's nurse in Canada, bleeding disorders nurse. And I was just looking thank you for everybody for sharing your stories, and just on what you said about the purple folder and, arming yourself with your sister, making those phone calls and stuff. Like what messages can you give to us nurses in the room to better arm you guys to deal with these situations? I do call ahead, I do call the emerges and stuff, but how do I empower you guys? With my assistance, but what if I'm not there? What if it's a weekend? What if it's is it giving you all your records every time you come to us? We do it for our obstetrical patients when they're going into delivery, and if they, they have their obstetrical letter and plan from Dr. James, but what about the rest of you? Is there any advice that you would give us as nurses?
So I'm very fortunate to have nurses. I mean, when I lived in France, I had a great nurse, Patricia, I don't know if she's still in the room. And then in New York Presbyterian, Donna Cardy, they are truly my biggest supporters. When I've had emergencies, they do just as you say. They call ahead the ER and they tell them that I'm coming in, and then they will send the hematologist on call. So I think having that go-to person to me is the biggest thing. I don't think that, right now, seriously, my file thing is humongous. I don't always carry it, honestly, but because I think that having them as my voice, and she also shields me from unnecessary things that sometimes they ask you to do when you go into the ER. Unnecessary tests to prove, for example, that I have a fibrinogenemia and things of those sorts. So I feel like just having them, she to me is more like a friend than a nurse. She is my person when I'm in trouble.
Do you want to make a final? Oh, sorry, on you go.
Sorry, I just wanted to say, and I apologize for all nurses for saying that you're a nightmare patient. I can't believe you've received that, and I'm sorry that you have been, over your life, have felt that way. Because I would appreciate you giving me all the information. I would take it in, and, so.
Okay.
I think it's really important to make campaigns to be visible for everywhere or for everyone, because so many people are thinking in the world and that women can't bleed. So sometimes it's really simple. Have just a part of your hand red, a little ribbon, and say, talking, take just a minute, to talk about women, they can bleed. It's very, very important to do this kind of campaign. So come up and meet. We have some for you.
Okay. Okay, so why don't we just have, if each of the panelists would just like to make some final comments. We'll start with you, Richa.
So thank you so much for listening for the story which you have given, and I'm just culling out information from what could be the strategies to diminish the impact of the bleeding disorders in women. And some of them would be, just to summarize, is as a woman said, to go to the camp and sending women to the camp. So we have sort of a peer support group, and we do have a women camp where we suggest and invite all the families and do counsel them to come, because again, sending their daughters to camp is again a big issue for them. So one is that. Education is another very, very much important, and empowering these women that they are so much important, their body, to see, and sometimes they have their problem with the bodily image. So talking all these things in the group. Also to have a peer-to-peer support. So we also look at that program where peer-to-peer support, where they educate themselves. Coming from the listening part, we encourage in the group setting, the support group, to listen to the stories, because only by listening, many things can get solved. So they talk about, and we give that networking, that space to be there. And if the healthcare providers are also available to give them some answers to their questions, that is very, very much helpful. So these are a few of the interventions or strategies which can be followed with them. Thank you.
Thank you.
Okay, so you had asked us what would be the advice that would give to others. So that's what I would like to close. So of course, the first advice is read my book. You can find plenty of advice there. But no, in all seriousness, I mean, 3 things that I would say. To patients, listen to your body. There's a lot of things that you can learn just by listening. You are going through a lot of busyness every day in your work and things that you're doing, and you sometimes disregard symptoms. So I would say, as a patient, listen to your body is the first thing. The second one that we've talked about before is create your team. Have that go-to person nurse, that go-to doctor, that you could really develop this relationship that you can care for yourself. And then the third one is face your own struggles, whatever they are, with grace. I feel that one of the things that I've found in having a bleeding disorder is sometimes they look at you and they're like, oh, poor you, or even with breast cancer, they would treat me like, you're the walking dead, and that's not true. So that would be the third piece, is like every day enjoy it as much as you can, because you don't know what's going to come up next, and face it with a head high.
Thank you. Paula.
So 2 things. One, I'm really glad that towards the end here, we started focusing more on the role of the nurse. And so I want to acknowledge Lisa, but all of the nurses who are in the room, and just thinking about how could I care for patients better, it actually would be to have more of Lisa. So she doesn't get paid to do call, and she makes herself available to our patients at her own personal cost, after hours and on the weekend on a regular basis. And so one of the things I'm going to go back and do is advocate for that to change at our institution. I don't know if I'll actually succeed, but I'll try. The second thing I want to say that I'm going to take away from this is, Lisa mentioned, we actually do always give my consult note with the labor and delivery plan to patients. I don't know why. We should do that for everything. So when we get back, we're actually going to think about a way of doing that. I mean, honestly, maybe the CCs on my dictations, every patient should get a copy of their clinic letter. Why not?
I've been doing that for years, can I say. All of my patients all get a copy of their clinical letter. And it's really helpful.
So my takeaway is I'm going to continue to be engaged. So I'm going to challenge folks in the room. So those who have a bleeding disorder, like, I beg you to get engaged. It's the time of the woman. You are a woman. Hear yourself roar. If you are not a woman with bleeding disorder, be curious. You know, the more folks that are curious about the disorder, are curious about finding ways to help us get our voices out, we can create change. So if we want things to move quicker, I think the more we articulate, the more we engage, the more we communicate and show curiosity, we'll be able to move forward. So that would be my feedback.
Thank you. Well, I would like to take the opportunity to thank Richa and Paula for agreeing to be part of the panel, but in particular, I would like to thank Joanna and Karen for their bravery in sharing aspects of their lives with us, and I'd like to thank all of the people in the audience who came up and shared their stories. I think what I take away from this is, it's a phrase in Maori, he tangata, he tangata, he tangata. It's the people, it's the people, it's the people. Thanks for your time.